I had this little Honda 70 and would tool around, and I was about 12 at the time, and it stopped working. And I tried a few things. I looked at the spark plug, looked at the gap spark plug, did different things.
12 years old, and you're
I'm
like,
12. And my dad just, it comes up with, Dad, I can't get my motorcycle running. And so you know what he does? He goes down to Honda and buys the manual. Here, son, figure it out. And I mean, I think I actually might have even cried at the time. But
fair.
But it's kind of like, well, but we had a barn with full tools and everything it takes to fix tractors and everything else. So I thought, well, let's start at the beginning. I took that thing apart, put it back together again, and it was running. So, I mean, these things that, you know, when we're kids, the experiences that we get that we might initially think are not the greatest experiences also help you build up, you know, your confidence that, hey, you can do things, you can solve problems.
Welcome back to the Spine Pod. We are in Shreveport, Louisiana, and we sat down with Dr. Pierce Nunley, and we're scrubbed up.
We're scrubbed up today. We are coming live from the OR. This is our first episode from the OR. It's amazing. You know, we've been in surgery centers and hospitals and offices, and we
cadaver labs.
Yes, cadaver labs. And we're coming straight from the OR. And what an incredible OR here. Spine Center of Excellence right outside of Shreveport, Louisiana. And there's not a better person to do it with than Dr. Pierce Nunley. We know him so well, and what an incredible episode.
Such a good episode. Always love sitting down with him. We got to sit down with him just for a short period of time at NASS last year, which is so fun, but we got to come back to his domain and do a full episode, and he just doesn't disappoint. He has so many great just nuggets, and just the way he views medicine and how he, you know, is so engaged with every aspect of medicine in the spine industry. This is a great episode to listen to.
Well, for patients or other individuals that are running into him for the first time, see what he has created here, right? Spine Institute of Louisiana, the Spine Center of Excellence, and everything that he's done in the research realm. But you can see exactly why he's created that from his childhood and his parents and his mentors. He talks about his mom as an artist and his dad as a musician and him growing up on the farm. Yeah, absolutely. Yeah. And him growing up on the farm and being a tinkerer and a problem solver. And now he does the same thing through his research, right? And that comes from other doctors that he's been mentored with and he's worked with, Dr. David Selby and Mark Asher. And you can see how all of that has grown him into the person that he is and why he has such a big impact in the spine community.
I absolutely agree. He is a phenomenal person. We've loved getting to know him over the last several years, and I'm really excited to share this one with our audience.
This is great. And it's also really fun when you have a surgeon. We know his wife, we know Amy, and she's also a surgeon. Yep. So they've got a well-versed, very smart, amazing household, and we love to sit down with him. So this is a really fun one.
So enjoy this episode with Dr. Pierce Nunley.
It is a privilege today. We get to sit down with Dr. Pierce Nunley. So many people know you super well. For the people that don't, Dr. Nunley, you are the founder of the Spine Institute for Louisiana, the owner. You are the chairman over 15 years, I believe, the American Board of Spine Surgery.
Yep.
Also chairman, director of the Selby Spine Conference, was, I believe, coming up on the 29th year, almost 30 years.
Is crazy.
And what a special episode. We're coming to you live from the Spine Center of Excellence in the OR. This is
in the OR.
This is incredible.
Now, just so everybody knows, as soon as we're done, we're terminally cleaning the room. So if there are any regulatory people watching,
it's all above board here.
It's going to be all okay after we get done.
This is amazing. I mean, I haven't been over here yet. This is great. This is where I feel comfortable. So it's nice to be back in the OR.
It's definitely where I feel comfortable. This is my real office, right?
This is amazing. You know, we appreciate you taking the time. You are a man of so many titles, but I want to start right here where we're sitting. Talk about the inception of this. I mean, this place is immaculate, just outside of Shreveport. This is amazing. Talk about the surgery center here.
You know, it really, the journey started, again, about 25 years ago when I came to Shreveport and we started a surgery center. And then the Spine Institute of Louisiana was started in 2003. And 3 years after that, we started Specialist Hospitalist Report, which is a physician-owned, 100% physician-owned hospital. And that's across the river. And there we do inpatient and outpatient cases. But as business started to grow and we started to outgrow that facility, unfortunately, due to the ACA Act, particularly Part 6001, that prohibits any new physician-owned hospitals, you really can't grow. And so rather than, well, we did fight that, but to no avail all across the country. So one of the ways to expand that is to build an ambulatory surgery center. And that's what we did. So there's a lot of places that have ambulatory surgery centers, and most of the time they're multifactorial, they're multiple lines of business. But we felt that it was really important to build strictly a spine center of excellence, one that only did spine care. And when you have an environment like that, everybody from the front door to the back door does one thing, and that's spine. They don't have anything else to worry about. All the instruments, all the scrubs, everybody, all the nurses. It's a different kind of patient. And so that's the way we built our team to really service just spine patients. And it's been an amazing journey. As you can see around here, when we envisioned this, it wasn't just to build an ambulatory surgery center. As you can see in this operating room, it is full spec, one of the best operating rooms you can have in a hospital, much less an ambulatory surgery center.
Well, it's great. We got the full tour. I want to give a shout out to the CEO here, Blaine, who gave us the full tour and obviously is part of the inception of this and has done it many times, has experience in the past. And so I want to give a shout out for him to allow us to do this, right? Because this is a truly incredible room, and to be able to share this too. This is what modern spine looks like, and it's fun to be able to share that. Yeah,
it's great. And Blaine does an awesome job with his team. And I mean, it is a team thing. I mean, it's at the end of the day, you got to build a team, and then the team below that's got to build a team, and they do a really good job of that.
That's incredible. Well, when we start in the OR, I didn't want to skip that. So I wanted to start right where we were, but I want to bring it to the very first part of you as a person. You've been in practice for 30 years now. You were born in Lawrence, Kansas. Talk about your upbringing. Talk about what makes you you and what makes you tick.
Yeah. So I grew up in an interesting environment. My dad was a college professor at KU. And he was, his doctorate was in geography, but he was also in the Department of Computer Science and also Latin American Studies. And fluent in Spanish, I spent a much part of my first couple of years of life in Costa Rica and Guatemala, and where he was doing a lot of his work there. He was also in the Army and the Pentagon doing Latin American intelligence. And so I grew up in that educational environment. My mom was an artist. When I was 6, they decided to move out to this farm, and I grew up on a farm. And we had cows and horses and chickens, and I actually had to milk a cow every morning for a couple of years. So, you tell a 10-year-old, nobody wakes me up, right? You have to get up on your own. It's dark. It's cold in Kansas. It may be snow on the ground, and you got to go out to the barn, get the cow, milk the cow, bring it back, and then put it in the fridge, and then go take a shower, and then get ready to catch the school bus.
Oh my God.
I mean, some people would probably call that child abuse.
Yeah.
But his experiences like that, I think helped make me what I am. And probably another experience that comes to mind was I had this little Honda 70 and would tool around, and I was about 12 at the time, and it stopped working. And I tried a few things. I looked at the spark plug, looked at the gap of the spark plug, did different things.
12 years old, and you're
I'm
looking
12. And my dad just, it comes up and goes, Dad, I can't get my motorcycle running. And so you know what he does? He goes down to Honda and buys the manual. Here, son, figure it out. And I mean, I think I actually might have even cried at the time. But
fair.
But it's kind of like, but we had a barn with full tools and everything it takes to fix tractors and everything else. So I thought, well, let's start at the beginning. I took that thing apart, put it back together again, and it was running. So, I mean, these things that, when we're kids, the experiences that we get that we might initially think are not the greatest experiences also help you build up, your confidence that, hey, you can do things, you can solve problems.
It's amazing. You're a man of many titles in the OR, as a surgeon, as an owner. You're also a man of many titles, as you've just talked about. You're a musician, you're a pilot. I've heard you do a little bit of singing. I didn't know that you repaired motorcycles. Talk about, did that come from your parents? Did that come from time on the farm? That natural curiosity and that inkling to start learning?
It does. It's creativity. My dad was a professional guitarist and singer. He could probably sing literally thousands of songs. There was a comedian, old time, you guys are too young, but his name was Soupy Sales. And Dad used to perform with him. And when Dad was performing through college and graduate school, he would know so many songs that he would get on stage and he would pay people if they could name a song that he didn't know, if they would come and teach it to him.
Wow.
And he never forgot a song. He had a photographic memory. And so I grew up with that. My mom was also a singer, a flautist. And so we grew up singing. I mean, it's just what we did. I mean, people hang around watching TV. We would play and sing. And I was playing the violin at age 6. When I was 12, I started the guitar because girls didn't really dig the violin. so
you had to rebrand that.
Yeah, rebrand that. Let's pick up that. And my dad got up every morning at 3 a.m. and he meditated for an hour, did yoga for an hour, and did classical guitar, scales, and all that for an hour. That was the way he started every single day. And so I started playing the guitar, and then keyboards later on, and then bass and different instruments. I can do fairly well on the keyboard.
Those skills and traits, I think a lot of people would bucket that and say that's separate from what you do now. Do you bring any of what you do there into what you're doing now? On a daily
Everything.
basis?
I think one of the things about children learning music is so important for just wiring your brain and wiring the left and the right. When I take those tests that say are they left brain or right brain, I'm always right in the middle. And I'm left eye dominant, but like in tennis, I serve with my left arm and I play ground strokes with my right. I mean, so I think a lot of the creativity that happens with music and developing those type of things really helps, because surgery is both a very technical aspect and both a creative aspect to it. So just the case that I came out of was very unexpected. There were some old screws that were 20 years old and we didn't have the right tools to remove it. And so we had to come up with something different. And so it's like that, where you have to have the creativity of okay, plan A didn't work, plan B didn't work, what's plan C? And so people that are really good at what they do in surgery, I think a lot of them, you'll find that a lot of them did music when they were younger. They may not still be doing it, but a lot of those synapses that kind of happen and build kind of how our brain works, I think is very important. And so again, if there's any people out there that have kids, get them into music, get them doing something. And I also like instruments that make you tune. So like the violin, the guitar, you have to tune the guitar, but then you play it. But a violin or any non-fretted instrument is really good because every note has to be tuned.
What I love about that too, I think what I keep thinking about when I'm hearing your story is, from a child, you had to have persistence. You had to believe in yourself. And I think that creates a confidence to be able to try other things, take new things on. And like, what a beautiful life your family had from doing that, right? And then you really have to have that to be in medicine too. So having all of those experiences as a child, what led you to decide medicine was the direction you were going to focus on?
Well, okay. So if we're going to get real honest about it.
Let's be honest.
Yeah. It was, quite frankly, a calling. It was interesting. I was, so my two brothers that are 6 and 8 years older than me were straight A students. One was a career pilot in the Navy. The other was a career officer in the Marine Corps, was in the JAG, and was a judge in the Marine Corps for his last 8 to 10 years of his 22 years in. And so I was following those footsteps, and I was also kind of creative and kind of flitty and all that sort of stuff. So I was kind of a B student, occasional C's, some A's, and my parents were riding me, and I think I was 15 at the time, and my parents went off to a retreat every year in Colorado, religious retreat, and they would, and they decided, it was almost simultaneous, we think, that they just said, you know what, we're done pushing him. I was 16 actually. So we're done pushing him, and he's either going to make it or he's not. And so I woke up one morning, and at the time I think I was thinking about maybe marine biology or something like that, and it just hit me. It's like, you're going to be a doctor. Like, literally, I know now that it was, a voice from God, a divine, but it was just a realization. It was not a question. It was like, you're going to be a doctor.
Like a knowing.
I said knowing. It was just boom.
Wow.
And so I'm like, damn, I'm going to have to make A's now.
Rebrand again.
And so, right. And so when my parents came home, they came in the door and I was all excited to tell them, hey, Mom, Dad, I'm going to be a doctor. And I said, you're really going to have to ride me hard now because I want to be a doctor. And they said, well, we had a discussion and good luck because we're not riding you. So you got it. You can do this. And so pretty much I was an A student after that. So, I mean, it was, and it was just a knowingness from then on that was my path. And everything that's kind of happened since then, even to the point of being here today, I think I've had a real guidance to be able to accomplish all this. If you look at my CV and the accomplishments and things like that, I mean, you don't do this alone.
Mm-hmm.
You just don't.
Can you talk about, I think that's a really important point. Talk about that discernment, and you kind of had just that voice that hit you that one day. I think that for you thought, this is exciting. I think for a lot of people that can be scary, right? Because you have to think through this process and like, wait a second, this is something I haven't thought about before. Do I have to, how far do I have to chase this thing down before I figure it out?
Do I want to even listen to it?
Yeah. So talk about that discernment.
Yeah. So it doesn't mean that it wasn't without stress, because once you set that, then whenever you fall short, which, occasionally I make a B or something like that. I mean, it would be very stressful.
Mm-hmm.
And so there was a lot of internal stress that I gave myself, and that kind of kept me motivated. And I'm very competitive. So, I mean, but mostly it's with myself. It's with other people too, but it's just so, but it's probably the at the end of the day, the knowingness of this is where you're headed. I mean, I never questioned that, but it's not without strife and, sometimes second guessing, what's going on. So, I mean, that's just part of life.
Yeah. I think sometimes when you have that, you think, oh, well, now I'm resolute forever on that one thing, but the trials and tribulations don't stop happening because you have that thought or that feeling, right?
No, I mean, one of the things that I tell people all the time is the one constant in life is change. Mm. And so you have to be able to embrace that change. I wouldn't be here. We wouldn't be sitting in this property if I wasn't willing to embrace change, and don't have to go into all the things, but we could have just sat where we were
mm-hmm.
and said, well, this is enough. And we could have solved problems a different way and not been here. So I think to be open to, what is right action and sort of divine intervention, and what, quite frankly, I used to not admit this when I was younger, but I use my gut feeling all the time. And I think that gut is hopefully sometimes tapped into a greater power. If you're really, if you're not conflicted otherwise. But I think that's important. It's interesting, even in my team, I got a nurse practitioner, Chris, who's been with me 25 years now. And another one that had retired last year that had been with me 20 some years. But we'd have a thing to where if all three of us had a bad gut feeling about something, it didn't matter what the studies were or anything else. And it was like, we don't operate. It's like, we're not operating. I mean, so there's something to that. There, going back actually to medical school, we used to do a yearly program called The Art in Medicine. And because, again, like we just talked about previously, there was a lot of medical students and allied health people that were either artists or in music. We would have a art festival and then a concert. And it was called The Art in Medicine. And so in medicine, if you look at the people that you respect the most, whether they admit it or not, there's definitely the aspect of science behind that they follow, but there's also this art part that you can't quite describe that really defines how they practice and how they make some decisions. It influences them.
I love that because I think also just thinking about patients and patients that are listening and trying to figure out who is the best doctor for me to go to, who is the best surgeon, you have to do a lot of gut feeling of, does this feel like the right procedure for me? Does this feel like the right surgeon for me? And like connecting to that is so important.
It's a very intimate thing, right? To have somebody that's going to potentially operate on you. And I think that when in a situation like that, I'm trying to be cognizant with my patients to say, look, you need to be comfortable with this. And for me, it may not be I may not be the right fit, even as much as you guys may like me. Some patients, they're just like, I'd rather go to Dr. So-and-so. And so I'm really good with patients. Like if they've seen me for second opinion, or if they want to go see second opinion, I'll say, look, if you feel more comfortable with that doctor and feel good about that, trust me, I'm good with that. And I'll give them records or whatever. And because at the end of the day, the patient is the one that has to feel comfortable with their choices.
As we talk about your journey in medicine, you went to school, hometown boy in Kansas, right? So you went to school, medical school in Kansas, and then you went to residency LSU. What made you make that jump? How did you decipher on LSU? Obviously, your training makes such a big difference on essentially the provider that you become down the road. So talk about your transition and kind of going through how you deciphered some of that.
Yeah. So the interesting thing, like I said earlier, it doesn't always feel good. LSU was my third choice. And so my first choice was Stanford. My second was Loyola. And then LSU was my third. Now, there were some other high-name schools that could have been in those. But the reason I even elevated to LSU to 3 was because of my experience here when I interviewed. The chairman at the time was amazing. They had to knock on the door 3 times to tell him that my interview was over. Because we weren't talking about medicine. I remember we were talking about the gold standard, how Nixon took us off the gold standard. And we were talking about world politics. We were talking about geography. And all these sort of things. And at the end of it, he looked at me and goes, "You're the exact kind of resident we need in this program." And I learned later that he was a man of few words, number one. So the fact that it was a long interview. And then 2, he never did not say what he meant, And so, that sat with me, but I was kind of wanting to go, to either San Francisco or Chicago and so there was a part of me that was disappointed that I got LSU. But as it turned out, it was absolutely the perfect place to go because I learned so much. It was a program, old school at the time, where, we really did all the surgeries. Staff was not present a whole lot of times. So we had to step up, grow up, operate, and do a lot of trauma back in the day and learn how to be a surgeon. And it was really hands-on. It's kind of like a MASH unit.
Mm-hmm.
When I rolled into LSU from Kansas, from KU, I thought I'd won into a third world country. I really did. I was like, oh my God.
Really?
I got to spend 5 years here. This is going to be a little difficult.
Shock to the system.
It was. Just a lot of stuff. Even like, for example, you don't talk about it much anymore, but like the racism part, I didn't really have exposure to that at KU. And when I came down here to the southern, area and it was actually Shreveport still is predominantly Black. And then just dealing with that and my other, white colleagues and all that sort of stuff that grew up down here. It was challenging. Mm-hmm. Things have changed, fortunately, but it was a shocker. So just kind of going through all of that and then the training program. But at the end of the day, it was absolutely the right training program for me. It gave me all the tools and skills that I needed to be able to operate. But then I needed the fellowships to kind of learn more of what to do, why to do it, and when not to, that type of thing.
Well, you tell the story of, you having a conversation and getting someone to chat and getting off topic. I don't know if I've ever had one of those with you. I mean, like if anybody can do it, it's incredible. I think you have this bedside too, and this sociability that makes you just this dynamic, right? Mm-hmm. I mean, you're obviously an incredible operator, but you have to have patients that have that comfort with you too, right? To really have that draw. I think
it goes back to like a patient can have a gut feeling of like, you feel like a real human and it feels authentic. And that's sometimes not something that you get,
Right. Yeah. I mean, I try to meet everybody where they are. Mm-hmm. It's interesting. I might even change the way I talk a little bit. People kind of will say, well, your accent will change talking to different patients and things. I just kind of naturally do that. I'll actually use different words sometimes. I mean, you always say you should talk at the level wherever they are, right? And so a lot of our literature is even at a 6th and 7th grade level, which is where it should be. So you can really convey true informed consent to the patients, right? And so, but I like to meet everybody where they are, right? So I'll walk into one room and I'll be dealing with a patient at this level and another room at that level, and I think that's one of the, like I heard one colleague say one time that, wouldn't it be great if you could just spend all your time in the OR? And it's like, no. I mean, I love being in the OR. I love fixing things, but I want to see them before and I want to see them after, good, bad, or indifferent. Most of it's good, but sometimes it's not. And you got to fix those problems. And, so I would rather have that experience of taking care of the patient and seeing them through a process, making them better and seeing how they change. And that's really, really important. And, in medicine, we get the privilege and the opportunity to meet all demographics. Most people don't get to interact with different demographics on a daily basis. They just don't. They meet with their coworkers and there are other people around them. There are people in their church or whatever. But you'll go from the poorest, uneducated to the highest educated, richest, and everything in between, laborers, trade people, and you really get, and literally going room to room, you get to see that cross section of society because everybody has back pain.
Yeah.
It's such a unique character to you. I think that's something that makes you such a good provider too, on that side that we love. You talked on fellowship. You talked about your fellowships. You did a little change of pace and you jumped over to the University of Basel in Switzerland, and you actually did 2 fellowships and you came back at Texas Southwestern. Talk about the impact of that and why go overseas? Why'd you go overseas to go find some of that training and do a fellowship over there and then come back and do another one here?
So I learned early on in my residency, as I heard some other people doing international fellowships, that first of all, they did things differently. And so I had already been over to Davos to learn the AO principles for fracture fixation. And it was interesting. I came back from that as a 4th year and I was then the expert as a resident, so I really liked the AO International. And they had a scholarship fellowship that they would allow some spine people. They would give to some a few graduates every year, and so I applied for it and I got it. And I think that what you learn is, first of all, living in another country is eye-opening in and of itself, right? It's just to say, hey, it's not all about the U.S. It's not all about what we do. You got to learn how to, go buy groceries and. You better be able to read German or else you're going to end up with something you didn't want, which I've done. I actually went and bought this really nice lunch meat. And all of a sudden I asked my buddy who was from Basel, I said, what's this? And he kind of looks at it, he goes, horse.
No.
Yes.
Did you eat it?
Yes.
How'd it taste?
It was very, very potent, I would say.
Potent.
Yeah, it was a very potent kind of meat. It was dark red. It was, you know,
Oh, man.
it was really, yeah. So yeah, horse. Yeah. So so anyway, you have to learn how to live in another country, and then learn why they do things. And the Swiss are, you know, a lot of the even early spine innovations came out of Switzerland and also out of Germany and also out of France. Coutel du Basset, the early fixation that became the CD instrumentation that then Medtronic was born from, was out of France, and then German and Switzerland were really a part of that. So to be in that and to study with those professors and be in the OR and learn how they do things, I brought techniques back that I used for 10 to 15 years. In fact, a couple that I still use.
Wow. That's amazing. And I want to touch on that point too. You know, you talk about training and learning from some of those folks. One of those folks that I want to touch on is Dr. David Selby. And, you know, you've had Selby Spine Conference for almost 30 years now. You know, he passed away in 97. You had to be one of his last fellows that went through that. Can you talk, and you've worked with other, Mark Asher, you know, some of these bigger names. Talk about what that training and that mentorship was like, especially that earlier in your career to work with just such big folks.
Yeah, and that goes back to when we were talking about how we're kind of divinely led,
Mm-hmm.
right? So I ended up doing a research here in the middle of medical school and just happened into Asher's lab. I was looking around who I could do some research with, and I wanted to go into orthopedics. So I wanted to do something in orthopedics, and this guy, Mark Asher. Who's Mark Asher? I don't know who Mark Asher was. And, you know, next thing I know, I'm in his lab. My first paper in spine was with Mark Asher and Tom Butler. Tom Butler was a resident at the time that I went to the VA and did all these biomechanic experiments where we, you know, took spines and essentially put them together and broke them and learned about it. And so that started, you know, you just don't know. And in fact, interesting about Mark Asher was such a gentleman, and as big as he was, and he's actually written a book that's really a great book that he actually autographed for me before he died. But he when I got an accomplishment, like won a paper award or won something, he would write a handwritten note to me and mail it to me.
What a lost art.
Whole out,
Amazing.
yeah, ooh. Just old school, right? So yeah, people don't do that much anymore, right? But having that kind of mentorship is important. And then Selby was the same way. It was kind of interesting. I had a professor, Bill Overdyke, who was awesome at total joints. And so they were working together with Wright Medical, which was a company at the time that had a joint division, had a spine division. And so Overdyke met Selby at a meeting. And I was thinking about going to fellowships and know what to do. I had the AO fellowship, and he says, you got to think about going to Dallas and do Selby's fellowship. And he had not done any fellowships in the last 2 years. He'd given it up. And he told me because he was tired of treating his competition. But anyway, so, but Overdyke had told me that, and I said, okay, well, that's kind of cool. And I blew it off. And it was like 3 months later, we're scrubbing in the sink, and Bill said, did you ever look into Selby and doing that fellowship? And I went, oh, God, okay, you know. And so after that case, I went to the library and I looked it up and I went, oh, hell, this guy's a big deal. And so I call him up. He gives me his number. I call him up and I said, hi, Dr. Selby. This is Pierce Nunley. I'm a resident. And he goes, oh, great. I said, wondered if it might be possible to be a fellow. Sure. I said, when you come, whenever you want. And I mean, was just a great guy. I didn't even know how much I was going to get paid. I didn't know anything. I came back from Switzerland. I landed in Dallas. And, you know, like it's the first week we're working, and he goes, you probably want to know if you're going to get paid. I go, yeah, that'd be good. And, you know, so, but he was such an amazing person. And I learned more from being with him in the clinic than I did in the OR. Mm. And just watching him, how he dealt with patients was amazing. You can't read this in a textbook. I remember there was a patient that was a year post-op, not doing well, and he was enraged. I mean, he was sitting here just about ready. And Selby was not a big guy. I mean, he was probably, 5'9" and maybe 140 pounds. And this guy was huge. He was a big guy, probably 250. And so, at one point I was in Kempo karate. And so I was still sitting there back there next to his dog. Shelty went to clinic. So the dog was in the room. Dog wasn't going to do anything, but I was just sitting there trying to be relaxed, but thinking, if this guy jumps for Selby, I got to take him out. I mean, seriously, you don't think about this, but I was really kind of on the ready. And I watched Selby just take him down and calm him down until the guy was just a puddle of tears, and got him kind of aligned, and basically everything was cool. And so to watch that and to see how you can not escalate a situation and de-escalate a situation and turn something that could have been really terrible and a bad ending to something that actually helped to get this guy back on the road to how we can make him better. Just stuff like that you can't read in a textbook.
You talk a lot about these folks and what you've learned from them, and incredible operators, right? Very well known. Mark Asher, David Selby. I think as individuals, you want to try and know when you're getting lucky, or when you're like in that space where you're like, I'm so fortunate to be here, and this is such a valuable, but it's tough to do when you're going right past it, right? And you're like in the middle of it, and you're
Correct.
busy and doing other things. But I think it's such an important aspect, to your point, when you're like, oh, this is something I need to hold on to and be aware of that.
It's interesting in life. A lot of times you don't know when you're in the middle of that. You only know afterwards. And then you kind of went, I wished I could have spent more time. And then back with Selby, I was his last fellow, unfortunately, and he died 3 months after I left the fellowship. And to me, it was a huge loss, because my other fellowship directors were in Switzerland, and he was going to be the one that was going to kind of open up the doors for me to be in different places in the societies and all that, and which is what mentors do. And all of a sudden he's dead. And I'm like, well, dude, you're on your own now. So, and it really was kind of a lonely feeling, because it's like, I don't have a mentor now that's going to help do that. So it's like back with the motorcycle and the manual. It's like, well, you're just going to have to do it on your own. Roll your sleeves up and let's go. And so I developed my practice to be a research type of practice. And then as we built the Spine Institute of Louisiana, and you look at any of the resumes of my partners, they're amazing. I mean, they otherwise would not be in Shreveport, Louisiana. And so, it's one of those things that you just expect excellence around you. You look for that, and you try to foster that in everybody, not just the doctors, but also the staff and the other people that we work with.
On its outset, when you see that and you say, I lost my mentor and this is such a tough time, the flip side of that is, think of what that valley built for your career, right? Like, you built on what he had started. He had that, he had that match, he had that flame, and now Spine Institute of Louisiana, Spine Center of Excellence, you've got all this incredible practice and research. I want to talk about research because coming up on PI of 40 studies, maybe more. I mean, it's incredible the work that you guys do here. Talk about the inception of that. Was that from the mentorship and from the learning? Was that from your early days of just tinkering on the farm? Like, what was it that really got you to dive into that research side of things?
Well, again, that does go back to being a child and having a dad as a professor who's, always looking at research. He's always reading dissertations and things of that nature. So I always want to know the whys, and I also want to prove it. Okay. So you can have an opinion, but an opinion is just that. And it can be based on a summation of what your understanding of the literature is. But a lot of times it's still an opinion. And so if you want to prove something and you have an idea, then you got to study it. And you need a quality study. And so I started, the sheets that we still use are almost verbatim what Selby had. I just took what he did. And so every patient that comes into my practice, we do patient-reported outcomes on every single one of them.
It's amazing.
Whether they're in a study or not. Now, sometimes it drives them nuts because they have to sit there on an iPad for 20 minutes. And literally, it's if you don't want to take the time to do that, then I'll help you find another doctor, because that data is important. And if you come to me and say, well, what's my chances of doing well after the surgery? I can tell you what mine are because I have my own data, right? If you don't have your data, you can't say. You can say, well, I think it's this. And if you don't follow up people, how do you know? But we try to follow up people. There's a lot of surgeons that may do a fusion. After 6 weeks, they say, if you have a problem, come back. Well, we don't. If we do a lumbar fusion, people are expected to come back at 3 months, 6 months, 1 year, and 2 years. That's the expectation. Now, they don't always do it, but we make the appointments and we may have that expectation. And even if they're coming in and doing well, it's great. That's a data point. We know that. And so I started on early wanting to be a part of doing these studies, even before I had a team. Then I built a team. And then shortly after Spine Institute of Louisiana opened up, we then created a 501c3 foundation. And that foundation then was our research arm. And that it will still exist, and we still do like an annual race for research, and we use those funds from the foundation to do our internal research. So anytime you do something and want to do a query about our own patients, that takes time, it takes effort, and so we're able to pay our clinical research associates to do that and create our own research internally, not just the things that we do for the FDA that we publish.
We got to know you through a lot of the clinical research, obviously. And I look across, you guys do so much clinical research. And I think it's incredible because patients get access to things that before they even come on the market, right? And when you're testing them and trying to figure out what that data looks like, and you want to go to places that do this all the time, right? And are well-versed in this. I'd love to dive into some of those buckets just because you do so much of it. And, you look across we talk about implants, cervical, lumbar, but the first one that I want to start with is non-instrumented procedures. And I know you do that stuff, and I know it's gaining in popularity. You were one of the first, I believe the first in the United States to insert PerQdisc in a laboratory setting as well. Talk about, PerQdisc and some of this other stuff, just the continuum of what that's looked like over time for non-instrumented, trials that you've done.
Yeah, so I wouldn't really call it non-instrument because you're still putting a device in there,
that's
but
true.
It's not a fusion. So you're talking about motion technology. And it's interesting, to some extent, nothing's new, right? So a lot of these ideas, for example, I was in the DASCOR pilot study, which was similar to PerQdisc, but it was a different polymer. It had a different construction to it, and it was also different the way that it was placed. And there are different nuclear technologies that have failed. And so, it's kind of, how do we come up with, because it seems like this should work. So how do we figure out how it should work? And so with the PerQdisc, there's a couple of proprietary things about it that make it different than the previous ones. One is access, and that rather than cut the annulus open or make a defect, we dilate the annulus through multiple dilators, so that when we pull those out, the annular fibers will close, at least partially, and repair that entrance point. The second is the device itself is more compliant and different than previous devices. And so, and the way that it's constructed internally with the pressurized systems and all that are very different than any device yet. So, yes, I was the first to implant a human in the United States. All the other ones were OUS, were out of the United States for the essential cases that went to the FDA that got us to where we are. But so I think it's really promising in the sense that we might be able to save motion segments and be able to do smaller procedures that allow people to avoid fusion and to avoid larger procedures in the future. And again, it's research, so we don't know how it's going to be. But if I also had this thought too earlier on that if you're going to be a surgeon, if you don't practice exactly the way you're kind of taught and what the standard of care is, if you veer from that, you're kind of experimenting, right? And so, which a lot of surgeons do. They do a lot of off-label stuff, but it's kind of like, well, you're doing that with what data? And so what research kind of allows us to do is that within a research project, it's okay because we're under stringent research protocol, and this is all good for science. We're collecting the data. If we're right, we'll prove we're right. And if we're not, like the DAS core didn't work. Okay, that device will never see the light of day. But like the flip side of it would be the Chorus device that we did in the 3-level cervical study, where the data is showing superiority. You know, when we started that study, there were some of my colleagues, including my partners, that thought, dude, you're nuts. Not really, but kind of like, I'm not doing that.
Yeah.
You know, I'm not flipping them over and doing that. 3-level ACDFs are great surgeries. Why would we want to do something different? All this sort of stuff. And the data now, level 1 data, because we randomized between just ACDF or flipping people and doing the fixation in the back, that they're not only doing as well, they're doing better. Fewer follow-up surgeries, fewer problems, back to work faster. I mean, all of these things. It's kind of antithetical of what you would think. But if you don't do the research and you don't randomize, and you would never know. I could just say, well, I did a bunch of these cases and they're great.
Mm-hmm.
Well, yeah, but what's your control group? You know, and that's the problem, is that a lot of people will say, well, I did a bunch of these and they're all great. Well, compared to what? And so when you do real research, you do have a comparison, and then you can make those comparisons and see. And one of the easiest ways to look at it is when we look at retrospective versus prospective studies. When you do a retrospective analysis, first of all, you have data problems because you don't have all the data points, and you don't know the full denominators, and you don't have follow-up as to the same level, right? But you're also, when you're collecting it prospectively, all of that data is collected real time, and then we look back at it. And the results are always less on the prospective data than they are on the retrospective data. And so when somebody does, say, a 3-level ACDF, just take your regular person in practice. I would say after 6 weeks or 3 months, probably greater than 70 or 80% of surgeons never see that patient back. So they don't know if they're doing well. They don't know how they're doing. They just assume they didn't see them back, so they're doing okay.
Mm-hmm.
Right? So, that's a great surgery. And when they talk about, well, I haven't had to do operations for pseudoarthrosis, it's like, well, but how many people came back with pain and you sent them to therapy? How many people did you do injections on? How many people went to other people because they weren't happy that they didn't do better with you and they went somewhere else? Do you know that? You don't know that because you don't follow them, right? So it's not a fault of the surgeon to think that all their 3 levels do great. But you have to look at the data. And that's what a prospective study does. So when we have greater than 90% follow-up, we're following up both sides, and we're talking to both sides and getting prospective data, and then we can truly compare them. And so it's eye-opening.
Mm-hmm.
I think it's such an important point. It's something that we touch on all the time, is essentially following the data instead of following your gut instinct or your belief on how something should operate, right?
Correct. And again, like we talked about earlier, you know, gut's important. Gut tells you a lot of things, right? On maybe what to do, but it's not the science part.
Right.
And you got to have both. You got to back both up.
You know, you do all this research, and I love, you know, your thought process, how thoughtful you are with the research that you do. How do you decide what studies you're going to take on, and which ones you say, this isn't something that I think is worth trying on my patients or adding to my tool belt for this period of time?
That's a great question. So it does have to start with something that I think is an interesting question. And so if it's not an interesting question, then I pass. Like, for example, we talked about that 3-level ACDF study. I thought, that's a truly interesting question. This is really cool. And at first, I thought that the patients are going to take longer to get over with the when we flipped them and did a 360, and then it was going to and it could potentially be worse and not any better. But I thought, you know what? It's a study. We'll find out. And I was wrong. My initial impression was wrong. So it's first got to answer an interesting question, and then you got to look into the protocol. That's where. So you may like the device, but sometimes the control is not something I would do to a family member. So it's got to pass the litmus test of, would I let a family member be in this study? That's a litmus test. It doesn't mean that I know that it's going to work, because it could be a new device like MOTUS or something like that. But would I allow a family member to be a part of the study? And if the answer is no, I'm out. But when you get down to the nitty gritty of the study of control levels and things of that nature, that's where sometimes we just we don't want to be involved. And if it's just studying something where we kind of already know the answer, I'm so busy. It's kind of like I don't have time for that.
You don't want to Me Too. You're looking for the new.
Like we're studying a new BMP that's really cool. In fact, I did one of the cases today, and it's really neat. It could be a whole lot better than Infuse. But again, it's got to go through the FDA protocol, and we're actually in the first phase of it where we're looking at dosing. So my patient today was a low dose patient, and so we go through that, and then if that works, then we go through the full pivotal study where we actually do hundreds of patients. But it's really cool. So that's a new bone graft that some of the negatives of Infuse, like leaching out into the foramen and then cervical spine causing, there's a black letter on using Infuse in the cervical spine. Maybe this would allow us to use BMP in the cervical spine, which would be great. So all these kind of things, it's like, it's a new molecule. It's a new way to do things. It could be really great. So that excites me. So that's fun.
I love this thread for patients because it's not just hard to find new technology, it's hard to find the right technology for what you're looking for.
Right.
When you look at, we're talking about cervical cases, when you look at cervical disc replacement, tons of cervical discs on the market, and you've been in 6, 7, 8 of those studies. Recently, Synergy with Bagheera. Talk about, as these new devices come out, what are new devices offering to patients that weren't on the market previously or that are upping the game of what cervical discs are out there?
So one of the things is imaging characteristics, and I think that's important. So a lot of the earlier devices, if you got an MRI, you couldn't see the neuroforamen at the level that you did the case, and so that can be an issue. And so some of the newer devices with the biomaterials that are in them allow them to do that. I think that the mechanics are slightly different, but the problem with cervical disc replacement, much like total joints way back in the day, is that you've got a theory about whether one is better than the other. But I don't know if we're ever going to get to really knowing which one's better, but we just have to look at the data. And, we're in a lot of studies, and the Bagheera will be out, I think, probably Q1 or Q2 of 26. So that'll be interesting. And that was a really cool device to be part of the trial. So I think it's exciting to have competition. And again, not all devices, M6 just got off the market because of some of the issues that they had. And so it doesn't always work out well. And the problem with the M6 that is a little scary when it comes to research is a lot of these were, late findings, 5-6 years out. So it's not like an early problem. Mm-hmm. And so that's eye-opening, right? So when we do research, it doesn't always turn out like we want it to.
I agree with that. And for patients too, some of these studies are not just single level studies, right? They're multi-level studies, which is something that we're growing into to try and get reimbursement around some of these things because you can't get them otherwise, right? With the single level cases.
Correct. And so there are, Highridge is starting a hybrid study right now. And so more and more studies are being created so that insurance companies will approve those. But it does bring a bigger question into, as we create all this technology, will anybody pay for it? Mm. And then the next step back from that is in order to do the studies, you have to have what?
Money.
Money.
Lots of money.
Money. Lots of money. Millions.
Yeah.
Like most of these IDE studies for a device, 40 million plus. Yeah. I mean, that's on the low side.
Yeah.
And so somebody's got to back that. And their ROI on that, it's not as bad as a drug, but you got to go from conception to the FDA study. That could be 4 years, through the study, another 4 years, 5 years. Then you get on the other side of it and you want to sell it, and you got to have a code. And you don't have a code, then they give you a T code. T codes don't pay. So next thing you know, you don't get it paid. Nobody's want to buy it. Blaine doesn't want to buy it to put in.
Blaine.
Blaine, darn it. So, blame it on Blaine. But I mean, seriously. So, I mean, I think that that's a bigger problem. So innovation, as we look at it today and into the future, has a lot to do with regulatory, and it has a lot to do with coding and reimbursement in a healthcare system where the dollars are shrinking every day.
I think that's such a good point. And, you are so well tapped into the industry. You do a lot of presentations, speaking events. Obviously, you're doing a bunch of research. So you see a lot of what's going on in the industry, innovation that's coming to the forefront. Also, how difficult it is to happen. Like, example, MOTUS, that's 20 years in the making. We're in the middle of the data collection phase for that trial. For a patient, once it gets on market, they'll have no idea that it took 20 years to get there, and, millions and millions of dollars. And it took, someone who's really willing to do that. What do you see how that has impacted the industry and the type of innovation that's happening that's fallen because of that, or directions we've moved in spine because of those barriers?
Yeah, I think it makes it extremely challenging. I think there are some technologies out there that probably do very well, but somebody's got to create the company and do that and get the money and the funds to actually do the studies. And it's not going to happen. And capital right now is pretty tight. We're in a regulatory environment that's a bit unknown right now under our current administration. And although it might improve, and there's some thoughts that will happen, we don't know yet. But that still doesn't get us past how do we get coding? And it's so political. It's extremely political. And it's just not an easy answer. And it's not just in the U.S. I mean, Europe is struggling itself, right? Their new rules changed, and they actually got worse than the FDA. So, but they are rethinking that currently, and so they may pull back. But their pendulum swung a little bit too hard. And that really stifled innovation in Europe big time, in the EU.
In the last, let's say, 5 years, has there been a shift in the types of studies that are even coming to your door for you to look at based off of this? Fusion is the standard of care, and there's a lot of let's innovate on fusion. It's a little harder to find things in motion preservation or outside of that. Have you seen impacts because of that?
Yeah, to some degree. I mean, I was thinking also about some of the research that we've done on postoperative pain, some of the things with some of the products that are used to try to decrease pain, decrease morphine equivalents, and decrease addictive substances. I think that's been a really interesting topic, and that's really more on the pharma side, where they have more dollars really than
God.
Right. Well, yeah. So that's a whole other political thing that I'm not going to probably go into. But yeah. So, the device side is it's challenging, right? And you have the coalition of all these companies, and the little guys are getting pushed out. So 20 years ago, tons of small little companies, and little companies could grow with new products and things of that nature. Now that's much more difficult. It's much more difficult to even be in a facility, for example, because most facilities have to limit the vendors that they have in order to get the pricing that they need. So it becomes extremely challenging for the innovators and the people that are coming out even with better ways of doing things. So, we have this process, as you know, called the 510K, where if it's a substantially equivalent device, the FDA will approve it. But you can do a lot of things with the tooling and with the way things are going to really make great improvements. But at the end of the day, if you do that, but you can't sell it, again, it's a problem.
Mm-hmm. Well, and again, like the end result, the patient, there's so many barriers for that patient before they even before it's something they'd even know about,
Correct.
Which is just insane to me. Like the amount of different hands in an OR that should not be in an OR.
Correct. I look back at, it's interesting the way insurance companies look at things. They call them experimental. We'll do a level 1 study. I mean, there's even some that are still saying that TDR is experimental. It's like, no, it's the most level 1 data that we've ever had on anything. You absolutely cannot say this is experimental. It's just, that just blows my brain when, so it's less now. But I mean, even like newer devices, like for example, the Intercept procedure. That's where we go in and do an ablation in the vertebral body. And, most, probably about half insurance companies are now covering it. But I mean, good level 1 data, good studies, and you're saving potentially somebody having a fusion. So it's kind of like, really? Why are we even having this conversation? As long as we meet the indications that were on label for the way the device was used in the study, why are we even having this conversation? And to your point, the patient is the one, because they don't have the money to afford to do it without it. Some do, but it's not that many.
Not standard across. Yeah.
No.
Yeah.
Well, it takes so many people out of that care continuum, essentially, right? Like they don't have that option now. It only now pertains to that small portion of people that can pay out of pocket. And then I think there's a secondary component that comes with that too, which is you don't have all the information. You don't know what all goes into it. And if you think, well, insurance isn't reimbursing this thing right now, it must not be a good option for me, right? And that's a terrible way to look at it. But I think it's an easy way for patients to make that jump. I mean, it's a logical jump if you're thinking that way, but that's not the case, right? That's not how it works.
And if you read these letters that the patients get, it's almost like your doctor's a terrible doctor because he's trying to experiment on you. It's like,
it's put on you.
Whoa,
Yeah.
wait a minute.
I know. I mean, you have an oath, do no harm. If you're in healthcare, I feel like anyone who touches healthcare needs to be following that same line. And that's just not the case.
No.
With a lot of different facets of it.
Correct. You're absolutely right.
It's amazing how complex it is. On a wrap on, we talked about cervical, we talked about non-instrumented. You've also been through the cycle. You just, there's lumbar disc. When we talk about lumbar cases, there's lumbar discs. And then you go through the cycle of what's all been, right? And you've got posterior stabilization, you've got Acadia and Stabilimax, and now you've got TOPS, which is a facet replacement. We got to know you through MOTUS, which is lumbar total joint replacement. I'd love to have you talk a little bit about that, which is now, the first lumbar total joint replacement. It's in the data collection phase, which we just went through. But talk about what that offers the patients and like the new opportunity there for a new technology.
The neatest thing about MOTUS is that, when you do a disc replacement, you're replacing the disc. And then the facet joints have to then function. And if they don't function, you end up with a problem. And that's not easily solvable. In fact, you'd think that, if I just fuse them, I'm going to do fine. But when you look at the studies that have done that, their outcomes are not that great. So it goes back to kind of one of the basic tenets of surgery, which is your best chance to solve the patient's problem is the first surgery. Mm. So if it takes you 3 surgeries to get to the same endpoint, they're not going to do as well as if you got to that endpoint for the first time. Now, that being said, sometimes it is best to do a microdiscectomy and not just jump to a fusion. So I'm not saying that. But if you know you're headed to a fusion and they're unstable and you're just trying to give them a small surgery to get them down the road until they get the fusion, that's just that you're trying to do good, but at the end of the day, you're not. Some of these gray hairs come from that. so I'm just telling you. But with MOTUS, the cool thing about, so disc replacements are for discs, And then the TOPS, which is also a lot of patients have facet primary disease, and they're having some instability, not bad, but they're starting to develop that. And if we can stabilize the facets, get rid of that, get the pressure off of the exiting nerve roots, that could be enough. But it doesn't replace the disc, and it doesn't stabilize the anterior column, right? So MOTUS is the first device, and again, we didn't come to this immediately. It was kind of like after the study, it's like, well, it's really a total joint replacement. You know, that kind of hit us one day. It's like, well, that's weird to say in the spine. How can you say that? But it fits. You know, in the knee, you got 2 condyles and you got a patella. You're replacing the whole joint, right? So in the spine, you've got the disc and you got the 2 facet joints. Same thing. So when you look at it mechanically, it's kind of weird when you look at it on an x-ray, but when you look at it from a mechanical standpoint, it truly does mechanically replace not only the disc and the anterior column and stabilizing the anterior column, but also stabilizes the facet joints and functions as a facet joint complex. So it looks weird, but in actuality, in a biomechanical situation, that's what it's doing. So that's truly exciting. And again, as we've talked about Me Too devices, it's not Me Too. It's completely different than any other device that's out there. So it'll be fascinating to continue to crunch this data and see how it turns out.
It's been great to know you through that process. You have given one of the best explanations. You talk about the 3-legged stool. I love it. It's so easy to visualize, and patients get it too, right? It's a 3-legged stool, right? Like you can't move one of the legs and you're not replacing one. Like it falls over. It doesn't work, right?
They all got to be stable.
Yeah. As we talk and we wrap up with some of this, just all the research that you've done, talk about some of the organizations you've been part of, because you're part of ISSG, huge research organization, you know, almost shifted from, it's almost 30 years around now too, from product development to outcomes-based research. And talk about how important that is and how much that's driven care as well.
I've been really privileged and honored to be a part of the International Spine Study Group, the ISSG. In fact, just came back from Johns Hopkins where we did our spring meeting, and it was interesting. A historian gave an hour lecture on that. And Johns Hopkins is where they really started the 4-year program of medicine, and also where they started residencies, because the residents used to live there and have to live there and weren't allowed to, they couldn't marry. They had to sign a contract, and their residency lasted as long as the professor said. So they could be there for 2 years, 3 years, 4 years, 5 years until they said, you're good to go. And they didn't get to pick what they wanted to be. The professor said, you're a urologist, you're OB-GYN, that's it. You didn't get to pick. They picked you, or they just said go away. I mean, it's amazing how the modern way that we do things, Johns Hopkins had such a pivotal, and women in medicine too. They were trying to finalize their medical school, and guess what? They needed $500,000 more. Now that's like $50 million now. And there was this wealthy young woman who started the first women's college in back east, and they wanted the money from her, and she said, you have to let women in the medical school class. And they were like, we're not going to do that. And they go, well, you're not getting my money. And they went like months. And they said, well, come on, can we do this? She's like, you want my money? That's what it's going to be. And so they took her money, and yes, women were in class at Johns Hopkins. So anyway, really cool story in history. But that's just part of being part of the ISSG. But what's great about it is that the minds in this, if you go to the website and just roll through, I'm so humbled, honestly. I mean, going back when I first went, I think it was 2009 when I was first in it. And I was around the room, and I was sitting next to Tom Errico, who was chair of spine at, I think, NYU at the time. And he was a sort of friend of mine at the time. And after the morning, I just felt like, ooh, I'm not sure if I belong here. I mean, really, like, these guys are way smarter than me. I mean, whoa. And I just told Tom, I said, I don't know if this is the right place for me. And he tapped me on the thigh, and he goes, Pierce, this is a good place for you. You just hang on, and you'll be good for them, they'll be good for you, and it'll all work out. And it really has been, because we all bring our kind of superpowers. One of mine compared to them is almost all of them are academic. Mm-hmm. And so I'm more private based, although I practice academically, But the business side of it and understanding, one of the papers I wrote was on the DRGs of how you bill appropriate all these big surgeries that we do, because they weren't doing it correctly and their departments were telling them that they were upside down and they weren't making money. And it's like, well, are you coding it and billing it correctly? So that was one of the things I brought to them, so everybody kind of wins. We all get together and we really push the needle. I mean, when you look at alignment, and I think it was before Polly, but Polly gets the credit for it. It said, we're all deformity surgeons. We're either fixing them or we're creating them.
That's one way to put it.
And it's true, because if you don't look at your PIL mismatch, and you get these high PI patients, pelvic incidence patients, and you're not mindful of that, and you're doing just a simple 1-level fusion, but they're already off, and you don't try to correct that, right? Then you've set them up for more surgeries. And so a surgeon that doesn't get full-length films and doesn't look at that and doesn't pay attention to that will every once in a while create a problem when they're well-intended. They didn't mean to. They were just fixing the problem at hand, but they caused downstream problems. And so the ISSG has led that whole PIL mismatch, and now it's a thing. Now doctors are talking about it, and they're actually measuring it before they're doing simple 1 and 2 level surgeries, because 1 and 2 level surgeries aren't necessarily that simple.
It's such an incredible list of names too. That's part of that group. We know Dr. Alan Daniels, Dr. Basil Debo out east. Even you look at some of the biomechanics folks and Virginia Lafage and all that. When you talk about this and we talk about global alignment and segmental alignment, the work that's being done is driving a lot of that, right? And how we believe and how we look at it. When we go back to MOTUS, one of the things that I get excited about, we're not going to know what this looks like until the data comes in, but like having a device that we know that there is some variability between spines person to person, right? It is not the same for every single person. So almost being able to find your balance afterwards, right? With a motion device, obviously you want to get them as neutral as possible, but if you have a motion segment through there, a total joint, you might be able to, even if you're 5 degrees off, your body will find some of that balance, right?
Correct.
Which will be really interesting to see as we continue to do some of this research down the road.
No, I think that's precisely correct, because I think the body does try to find neutral, right? And if you create a situation that makes it harder, it's going to resist that, which causes a breakdown and causes downstream problems. So yeah, it's fascinating. All of this is really fascinating.
It's great. We look at that. Also, I want to talk about what was just founded. I found out about it just last week. Global Spine Initiative, your group. You want to talk about that? That I saw it in the last week here, and I was like, can he take on another activity? I wasn't sure if he could. Tell our audience what that's about.
Did you talk to my wife about that? Yeah. Maybe he's like, you're taking on one more thing?
She sent us here to have a conversation.
That's right. Well, you did talk to her at ISSG. That's right. So, not to add one more thing, but again, like I said about research, it's got to be something meaningful. So I've been involved kind of on both sides of the fence between the surgeons and the interventionalists from day one. I did IDET back when I had black hair, back in 99, right? And so I do my own injections on some of my patients and RFAs and things of that nature. And then I've been involved like in Vertiflex and the Superion device. And I was actually one of the doctors in the panel that defended it and got it across it. That was a long day. But so I've been involved with these interventional devices and including Camber and the Versa device. And so with that, the interventional kind of community is reached across the line. And I've worked in some of the interdiscal stuff with some of the pioneers. And they basically said, hey, would you kind of come be part of this? So the Aspen meeting I've been involved with, I'm going again this year and being on a couple of panels. And it was actually a brainchild a little bit of Stephen Hochschuler, who, he's a thought leader, always has been. And the problem with interventionalists is that they don't really, their training programs are probably, it's interesting to talk about Johns Hopkins because, prior to them, you could have like a 2-month thing and you're a doctor, or you can be an apprentice and now you're a doctor. And, they set a 4-year period that you had to go through. And so part of a lot of the interventional treatments is their training is maybe not the best. And although they mean well, it's like, what are your indications? How are you doing this? And so they're catching a lot of flack from surgeons that are seeing failures, right? And that's appropriate. But then the flip side is, well, but they didn't know any better. And then also there's a bit of messaging about, who's appropriate to take care of what. And there's a bit of a turf battle. And I look at it as similar to what cardiothoracic surgery and cardiologists were 30 years ago, right? So back then, it was like the cardiothoracic surgeons, it was their world. And the cardiologists were, their peeps, Well, that's the way the surgeons look at it now. But if you look at the numbers of interventionalists out there and the way they organize and the way they get together, they're much more organized than the surgeons are. And they're much more cohesive. And they are really, I believe, sort of taking over the primary care of spine and will be controlling the patients, I believe, one day. And interesting, in the last meeting I was at, we had a little bit of an argument about that in one of the panels. But I think that in this coming environment where you have the surgeons and you have the interventionalists, there needs to be sort of a common ground where we agree that we can get together and decide on a path forward that works for both sides. And so that's the purpose of GSI, is to basically say, we've got surgeons representing, we got interventionalists. The interventionalists want to do the best thing they can, get the best training, and really guide the interventionalists to doing best in class. And then the surgeons want to help with that and also help kind of bridge some of the gaps of telling some of the surgeons, hey, back off. These guys can do this. If they're appropriately trained and appropriately doing these procedures, don't be such a naysayer. They're part of this continuum, and let's work together. And rather than this, this thought process of the pain guys, I'm controlling the spine, I'm never going to send them to a surgeon because surgeons are bad. That's not good either. Mm-hmm. We need to teach the interventionalists, hey, we do some pretty cool stuff. And we do a lot of minimally invasive stuff, or maybe even some major things. But you know what? Sometimes patients need that. That's what they need. And so part of this is educating them. We're not the bad guys. We're the good guys. We're all here to take care of the patient. So maybe you can learn what we do that's good so that we can work together. You can send us patients when it's appropriate. We'll send you guys patients when it's appropriate, and we'll all work together. And it won't be this turf battle. And so that's sort of the reason that is the reason I'm involved. And it's an amazing group that are very motivated, and I think will help move the needle.
Again, if you think about patients, that's what patients deserve. Everyone should be talking to each other and
Correct.
Fix the gap that's there.
Correct.
As we wrap up here, we were really lucky when you were just talking about ISAS. We did get to meet your wife. And not only is she a sweetheart and fantastic, so nice, she was incredible, she's also a surgeon. Your wife is also a surgeon. Can you talk about that a little bit? I mean, what an incredible situation to have two surgeons in the same household, and what that's been like. I mean, that's amazing.
Yeah, my wife actually, she's retired now. She was a breast surgeon. I think did, 3,700 breast cancer surgeries in her career. So even though her career was only 20 some years, she worked 12 plus hour days, saw consults at 7 p.m. at night, spent an hour with every consult. I mean, she was amazing, an amazing surgeon. I think the thing that helps there is that she can understand where I'm coming from. Right. And, if I want to go home and talk shop, I mean, we don't do that a lot, but she understands. If I have a hard day or have a hard time in the OR, I get it. It always helps to have a companion that you're really on the same level with. In fact, she's smarter than I am, but you know, I mean, she's brilliant, but, you know, there's always somebody behind the successful person that's probably really one of the reasons why they're so successful. And definitely Amy's in that category.
We could see that when we met her at ISSG. We're like, she is incredible. She is the other half of you. That's
I'm way
amazing.
overmarried. I mean, yeah, she's truly amazing in so many different ways.
That's incredible. Well, again, we know you've got enough going on. As you said, this is incredible. Being able to sit here in the OR, Spine Center of Excellence, you know, I think this is so special. You know, you talk about being humbled. We're humbled to, one, know you, but two, that you take all the time that you do. We've gotten to know you over the last 4 or 5 years. Absolutely incredible. There's so much more to come. You know, one of the things that really stuck with me as we sat here, and we touched about it in the last little bit, we talked about Johns Hopkins and, you know, women getting into medicine and how that all portrays. You know, I think sometimes innovation and progress is forced, right? That was one of those situations where it becomes forced. I think we're going to see more of that with the technology side, right? Obviously it's complex, but things can be forced through outcomes measurement, right?
Correct.
Data doesn't lie. And so sooner or later, as long as we collect more and more of this data and we continue to follow it, you know, insurance is going to have a say and all these other people are going to have a say. But when we're looking at outcomes, that can start to force some of the innovation and start some of the progress.
And you're absolutely correct. I think I still remember back, this is probably 20 years ago, Kevin Foley was on stage talking about cervical stems after ACDFs. And some guy in the audience was just irate. I mean, he got up and was just on the microphone, just, I forget all he was saying. But Kevin would kind of, you know, Kevin's calm. So he's just like, well, you know, the data shows this, and actually it's, you know, we really found this, and it was significant, and then the guy's and Kevin just finally just kind of went up to the mic and he goes, well, sir, all I can say is I have data and you don't.
Solves the argument.
And I was just, ouch. I mean, everybody, this was at NAS where there was a balcony, because I remember I was on the balcony. So it was a huge, there was probably 4,000 people there. It's like,
did it shut him up?
No, he was done. He was done. It was schooled. Just totally schooled. And I just thought, you know, so to that point, you know, at some point, you're at that point to say, well, I know you have your opinion, but I've got data. So sorry.
That's what we try and reiterate as much as we can. And that's what we resonate with surgeons like you is we're going to follow the data, right? We're going to continue to test. We're going to follow the data and look at the right things. You know, for people, there's so much content that you create out there. People can find you obviously here, can find you on YouTube, but for patients that are looking for you, whether they want to come have a visit, a second consult, or just get educational material, LinkedIn is a great place. YouTube is a great place. How can patients find you?
Yeah, so LinkedIn's great. And then also Spine Institute of Louisiana. So .org, louisianaspine.org is our website. And again, I've got great partners, so it's not all about me. You know, I think this is a great facility, and I truly feel blessed to be a part of this and to be able to practice where we're practicing.
We feel super blessed too. You know, huge thank you to you. Have so much, you know, just humbled to be able to be here, to Blaine for giving us this, you know, this amazing OR, letting us set up for the day. So thank you for taking the time. Thank you for sharing your story with the patients. We really appreciate it. And we will continue to watch everything you do. Thank you, Dr. Nunley.
You're welcome.
Thank you.
Y'all take care.
You too.